Welcome back to the Midwifery Wisdom Podcast. This week, we're joined again by our co-host, Augustine Colebrook, as she meets with a special guest, Dr. Victoria Flores, a hospital OBGYN turned community provider. Victoria shares all about her experience going from hospital OBGYN, her residency, the gaslighting she experienced in that process, to leaving the hospital and working with Homebirth midwives and other providers in the area. Stu Fishbein, one of the names she drops. Both Augustine and Victoria together dive into the roots of modern medicine and where they think it went wrong. They talk about the importance of keeping mamas and babies together, the vital period of the 4th trimester, and wrap it all up with where Victoria got her faith in birth and some wisdom she has to share with midwives and providers in the birth world. This is a power-packed episode. You are going to leave feeling excited to continue serving mothers and women around you. Let's dive in.
A big official welcome to the podcast, and thank you so much. We've been working on this for literally 1 year, and here we are. Schedules aligned.
It's taken a long time to get us together finally. And I think it's only just because you're moving so much, and it's hard. You're a mover.
Yeah, I'm not in one place for very long. That is true, but busy. Let's talk about busy. You are busy, friend. I've seen you all over the internet, all the babies, all the conferences, all the talks. It's awesome.
It's a lot, and I'm definitely trying to step back more this next year, which is kind of a bummer for some people to hear, I'm sure. But yeah, I think I got my feet wet, and it was wonderful. Yeah,
it's awesome. And the balance, and that is an ever changing, evolving process. We're all learning how to set boundaries, and we're learning how to find that work-life balance. And so I applaud that effort, whatever that looks like for you. And awesome. Well, so there may be a few folks who don't know who you are. I hope they aren't many, because what you're doing is really, really exciting. Okay. And I'm really grateful you're here joining us for this episode. But let's do a kind of a deep dive intro. And I really want to encourage you to take as long as it takes to tell this story. So tell us who you are, where you are, and what do you do?
I'm Victoria Flores. I am an MD. Weirdly, it's weird saying that, because I don't know, I still kind of have that, what do you call it? Like that complex everyone talks about. You don't feel like it, and what is it called? Where you feel like you're not quite that. Yeah, that's me.
Imposter syndrome.
Imposter syndrome. I have that a lot. And, I think I got that because I was always kind of a petite girl with a super feminine energy and quiet. I was more of a quiet type, believe it or not, although I was a cheerleader. I think I got those positions because I was good more than because I was outgoing. Yeah, so I was kind of a little bit more of a nervous around people. I've always been kind of that person. And so I've always been in the books. I've been a book nerd, reading, getting myself involved in health information since a very young age. I can remember even my parents showing me videos, because this is when there was videos, of like survivor stories. People, how did they survive in the wild? And they would talk about like, oh, they got cut up from falling out of a plane, and then there was these maggots that they had to clean out, and they had to wash their cuts and reset their bones and like walk along the river downstream to a village. And I was like, yeah, I love that. And I was so into that adventure-y, like how to like manage life with no one around, nature loving. Like I just wanted to be independent since a very young age. And I was the weirdo because I would even bring those videos for show and tell, and no one else cared. Everyone was like, weird, like, why do you like this stuff? Like, you're a dark person. And I was like, yeah, I am a kind of dark person. And no one else like in my family ever like made fun of me for it. So I had a safe space to do that, lock myself in a room and explore those energies. And I've just kind of lived there the whole time. And so when I went to undergrad, I was a sciencey kind of girl. I did neurobiology at UC Irvine. And then after that, I went into USC for medical school. And I kind of always had this idea that I was going to be a baby person, a person who delivers babies. Like I just always did. Like, for example, I began school taking like feminist classes, and I always did like art in the feminist realms, you know, at those era. It was like 2005, 2006. And then when I got to like UC Irvine, I joined a lab that was specific to toxicology and environmental toxicology and the effects on reproduction. And I was like, oh, I could use this. So I knew about helping women's reproductive organs from very, very young, like 18, 19. I was all about it from that point. And then when I got into medical school, I was like, I'm going to be an OBGYN. Like, there's nothing else I want to do. And like, I did all my rotations, and it was fun learning because I like learning. But OB is what I wanted to do. And it was really funny because that was actually a group that I didn't fit in with, but I knew I wanted to do that. And so it was kind of challenging to be like, okay, I need to fit in with them. But then I'm also this, like, you know, they do that big 5 or big 4 personality test, the ocean one, right? I'm a very disagreeable person, like very. I
love that. I love that.
Disagreeable. Yeah, it's like bad, and I cannot change it. I cannot. I've tried. I mean, I've gotten better at just holding my tongue 100%, because a lot of people say things that I disagree with or can disprove, but I just don't talk now. That's how I've improved it.
Well, I'm a big fan of being yourself, so keep going. Yeah.
So I also, because of that personality trait, and you know, it's like who you are that comes out. Like, I don't make friends super easily. Like, and I'm very picky. And so I think when I got into residency, it was just very obvious that, and I mean, even if the girls that are in my program there, they know, like, I don't like them. They don't like me. We didn't like each other. And it was really hard for us to work together. And I just wanted to not do it the way they wanted to do it. And then that was the way that I had to do it. And it was like, okay, well then fuck this. And I was like, okay, you guys and I are suffering so much. Like, let's just not be together. And we broke up. Like, I broke up with the program, they broke up with me. Well, I was more like, I just applied to other places. I applied 2 years to other places, and finally I was like, you know, I am going. The first year I was like, okay, I'm gonna stick it out. And I had this terrible chief resident. She knows who she is. Supposedly she's changed because she's a terrible woman. The first day of the residency, I remember I had to go check everyone's like logia postpartum and come and talk to her about it. And she was asking me, well, why do women hemorrhage? And I like rattled off a bunch of things like, oh, macrosomic babies, twin babies, polyhydramnios, you know, multiparity, grand multiparity, all these things. And then she's like, well, did that woman have that? And I said, no. And she's like, well, why are you lying to me then? And so it was just a lot of miscommunication. I was like, you asked me what did it. I didn't know you were asking me what did it for her. Like, you know what I mean? And so just from day one, it was challenging to understand these girls and for them to understand me. Yeah, so there was like a lot of that. And then anyway, so then I went into Tufts afterwards, and it was wonderful. Like, the girls were so sweet, and I loved them. But then I just realized OBGYN wasn't for me. Like, I am not a person that wants to wake up at 5 a.m, show up and round at 5:30, 6 o'clock, talk at 6:30, bright and shiny to everybody, and tell people what to do. I'm not that kind of person. I'm not really I just didn't like it. It just made me sick. And then I'm also very connected to my moon. So during menses, I always wanted to be slower and stuff, but there was no space for that in OBGYN. Like, they want a male body who's not cycling energies, who's not changing. And I had to accept that.
That's so heavy. I just want to stop there for a quick second, because like, you just named like one of the most true and unspoken realities that we live with. And I just, they want male bodies that don't cycle. Woo.
Yeah. It's
okay.
So
sorry. That was just like,
Yeah, no, I'm actually going to
that's tweetable right there. Yeah,
I'm gonna pop a cherry on that for you, Augustine. So
okay, let's hear it.
My first year of residency, I had a severe period one day just because of the stress. You know how things go. You don't ovulate well, so you build ridiculously thick linings. And so I was in the middle of a DNC for whatever happened, spontaneous abortion or something, and I was just bleeding through my scrubs. I'm like, what are those called again?
Yeah. Yeah.
That's right. And so, and then I had to exit in the middle of the procedure while my chief was finishing up. And I went to the bathroom, and then I couldn't even get out of the bathroom. And then I had to be wheelchaired across L&D to get to the call room and lay down for the rest of the day. And I was groaning in pain, trying to push out these clots. And this is just what happens when you get to that point. And I remember some doctors or nurses telling me, you're going to scare the patients. And I was like, I'm in so much pain and dying, and you're telling me to shut up while I'm suffering. And it was so traumatic. And then I was never invited for the rest of the year to do a DNC my intern year, which is fucked up. That is not how you train somebody to get back at them for leaving during a procedure because they were on their period. That's what happened.
Whoa.
Yeah.
Whoa. That's
true.
So intense.
That was a Dr. Moxley. He knows that. Yep. And my chief knows who she is. She's so proud.
Well, I'm so impressed that you made it through. Can I just say that? Like, when you get that level of gaslit and abused and neglected and all the things, like, high five for making it through. Like, seriously, that's intense. Yeah.
Thank you, love. Thank you. Yeah. It's a lot for me still to think about when I go there.
Yeah.
But I made it through enough. I actually did leave a little early.
Since we're on this conversation really quickly, I just wanted to circle back to your very first comment. Have you seen, what is her name? It was at Smith College commencement speech this year. Rashma Saujani. I think that's her name.
I have not, no, but I will now that you've pointed
that out. We'll link it in the show notes, and you've got to go check this out. She's talking about the roots of imposter syndrome, and that it's absolutely rooted in the patriarchy. And she talks about bike face. Do you remember that invention, that medical diagnosis, bike face, back in like the 1800s, where like when women first got the access to the bike, they looked strained with red faces and they got diagnosed with something. Oh my God, it's so great. This is a great commencement speech, so inspiring, and it just made me so compassionate for you. Like everything you've gone through and who you are right now, totally changing paradigms and breaking through glass ceilings and like, doing the thing, revolution. It's amazing to hear that you have imposter syndrome, because it first of all, it humanizes you. I think we all deal with that, but more than that, I think it really emphasizes how there is no woman who is free from the patriarchy in the patriarchy.
100%.
And I just really appreciate you saying that. Thank you so much.
Thank you. And so midwives have been my safe space, and it's been really amazing.
Tell me about this. So what happened? What happened when you got out? What did you do?
Well, I was like, okay, I know I want to practice what I know, because I knew that I was brilliant, because my husband's a physician and he's a member of the Royal Society of Medicine and he's an award-winning author, and he's seen me compared to my peer group, and he's like, Victoria, you're fucking smarter than all of them. Like, you need to do stuff, except you just don't like to play the game. Like, so I'm like, I know. So what am I going to do? And so I had support from people that I trusted because they were validated by the patriarchal system. Right. And so I have an attending at my side for the rest of my life. And so I knew that I could always ask for help, even if I didn't, finish the board certification the way that they wanted me to, which is, thank God, because me and Stu both are over the certification stuff, right? Like, it's just way too much. Yeah, I don't want to have to be in that student space for the rest of my life, right? Yeah. So then I just decided, you know what, I can do it. I'm going to ask around to see how. I asked around. I found Stu. Stu and me actually met up after I was speaking to him initially while I was in Boston. And then when I got to California, me and him and my mom and his ex-wife all went out for drinks. Yeah, he's really friends with his ex-wife, and she's gorgeous. And
I know. It's the best.
It's amazing. Yeah, they have a beautiful daughter as well. And so we just had drinks and talked about how it worked. And then he was like, okay, just start coming to the clinic and let's see how it goes. And I did. And then he just basically was like, yeah, like you're doing what you should do, like just do it. And I started going to the births with him, and he would like ask the moms if it was okay if I was the one that helped with the breech, and they'd be like, it's kind of like in your zone. You don't really care, especially in the home birth world. Like it's not really like a student, and they knew that I was a physician already. It was just like, hey, could she watch right now? And so it began like that. And then I would just get some side calls from communities that couldn't afford him initially. And they're like, could you just do it for a little bit less? And it's like, yeah, do it. And so we would do it like that. And then I got my practice, and I knew I had
an apprenticeship. You had an apprenticeship.
I totally did. I had an apprenticeship. It was beautiful. And then being in those spaces with those midwives, helping those women, being a female myself, I could be involved, and I got to touch the women, but in a good way. You know what I mean? In the way that they wanted to be touched, massage them when the massages need to happen, walk with them when they needed to walk, serve them. It's so funny. I still have a tendency to serve a lot in the birth space, and people are kind of just like, hey, that's my job, the doula or something like that, like, or hey, stay like, and I was like, it's okay, you don't have to do that, doc, like, and I'm like, okay, fine. Or I'll be like cleaning up my stuff, and my assistant or something's like, hey, stop, you're tired, go chart, and I'm gonna do this. But like I like order, and I like serving, and I just like, I'm used to that. So I'm a wife, I'm a mom, so I'm used to that. And so, yeah, it just worked well in the birth space with midwives, and it's less shameful than, and it's funny because when I was in the hospital, they actually would make me clean up everything, because it's like, you have to do it until the nurses think that you're respectable enough that they'll do it for you. So there's that, lesson that's learned. So I had come out still with that energy of, okay, whenever I finish a delivery in the delivery room, I'm going to be the one that folds the sheets down, puts them in the bucket, wipes the mom down with soap and water, puts her pad on, puts her chonies back on, puts the stuff in the trash, puts all my instruments into like a bag, spray it with this special like enzyme, close the bag, and put it in something that's going to be autoclaved later. And like, that was my job. Like I had to do that at every birth. And so, yeah, so I just had a lot of that energy still. Like the old school attendings were the ones that stood in the back and waited for everyone to do everything for them. I never got to that place. So I never felt that. I don't know that feeling yet. So, I mean, I don't think I will. So I think
so do you ever want to be back in the hospital?
No. I don't even think I could, honestly. They'd be like, you'd have to start over again. And I'd be like, what? Really? Me? But like, no, I'm not going to. But there are people that do that, that come from other countries like India, that are brilliant doctors practicing forever. And then they have to do a freaking residency again and start from square one and go through hell and get pennies an hour, It's like, I think someone did the math, it's like $13 to $14 an hour with like the worst benefit ever. Like, and then they're running the hospital, because it is the residents running the hospital, even though everyone thinks, oh, they don't know what they're doing. They really are running the hospital. Yeah.
Totally.
So yeah, I'm not going back. No, I'm stuck. And so I think it was kind of like a burn the ship type of thing. Like, you remember that story, supposedly. So yeah, I burnt the ship, and now I have to stick on the island and figure it out, for better or worse. I'm dying here.
Well, I kind of love that. I mean, I don't love that you have less options, because I want everyone to have more options in birth and in provider world. But I love that the commitment is complete. Sometimes when there's an out, it's hard to, whatever. So it's just like in labor, like there's no epidural, we're having a home birth, and I love that about you.
100%. And that's what it's so funny when you get the calls and she's so uncomfortable, she can't get comfortable. And I know people that are listening that have heard me say this go, that's just a part of it. Like, you have to be uncomfortable. I'm sorry, it's not comfortable.
It's not optional. It's part of the process. All right. And if you go to the hospital, you will be very uncomfortable after you have the baby. Like there's discomfort is a part of this, no matter how it unfolds. Exactly. I love that. And Victoria, I just want to I just want to cheer for this turn of events, for the what I'm calling is like the revolution of space. So previous to what previous to the last few years, we've had advocacy and like these siloed care groups, right? We've had like OBs against midwives, and then within midwifery, we have like CNMs against CPMs. And, it's like there's these silos of providers, very few connections and bridges, and a whole lot of information hoarding, and a whole lot of scarcity, and a whole lot of fear, and a lot of persecution in all directions. Like, you're wrong if you do, blah, blah, blah. And, what I feel like, my organization, Midwifery Wisdom, is trying to usher in is this celebration of space. So there is a hospital-based provider and there is a community-based provider, and they generally have a pretty similar scope in those two locations. Yes. It doesn't have to do with how you came to the education. It has to do with where you practice.
100 bajillion% agree with you. I love that. You're either an out-of-hospital provider or an in-hospital provider, and that really defines what you do more than how you got to that space. 100%. Because once you get to that space, everyone helps each other, and we do the same energy alchemy. And that's what it is. Yes.
Yes. Yes. And so that if we can define ourselves by location of care, we will suddenly have allies that have been absent for us, right?
I love that. Oh my God, I love that so much. Yes, yes. That's one beautiful way to connect us all, because 100% I see the divisiveness amongst all peoples in every realm. Even in the hospital, it's the senior attendings versus the junior attendings. They don't know what they're doing. And then the junior attendings are trying to take it out on the, maybe the residents or maybe another type of surgeon. And everyone's saying, oh, the surgeons are the surgeons, not the OBGYNs. It's just constantly breaking itself down in that system as well. And, the LVNs versus the RNs versus the CNNs, there's so much of that. And then in the home birth world, yes, I see it too. It's like a licensed, unlicensed, CPM trained, traditionally trained, like all that stuff. So it's just so weird. Our human, it's just like so weird. It's so weird. But I like how you found a way to bring it together.
Thank you. Yeah. Well, we've had this knowledge that, divided they fall, right? Like like this division, this isolation based on training type is working in terms of not letting the industry, the space, the profession, we can't grow if we're constantly at each other. And I think part of it is that we live in a scarcity culture, but part of it is also a little bit by design, like the CNMs have been allowed in, but everyone else is out. And that's a little bit by design,
The CNMs were always there. They were actually RNs that were created by OB/GYN surgeons and told to become midwives because they didn't want to bring in traditional midwives. So they were always there. Yeah. So they actually didn't come into this space.
Yeah. And it's just been this division for decades now. And I think if we want to, we all know from all directions, especially public health, that the solution to the maternity health crisis in the United States is the midwifery model of care. Not necessarily midwives, but the midwifery model is really easier in the community-based space, clinics, birth centers, and home space. And so if we really band together as those folks, because you need a different skill set.
Yeah. You need to be
you need a different skill set in the hospital than you do.
Yeah. It's the family energy that you bring to your health and
energetically.
Yeah. And that's really detached.
The energetics for sure.
Yeah.
Yes. So detached. Oh my God. Yes. But it's also a clinical skill picture, right? So because care is so segmented in the hospital, there is someone that does every level of care. There's respiratory therapy and phlebotomy and pharmacology. And then you call in your NICU nurse, and then you call in your janitor, right? It's all segmented. But in the community-based space, it is not. One provider has to have skill in all areas. And so there's very different skill sets in the two care locations.
Yeah, totally. And that's why, people and family medicine doctors will laugh at this because they know it. People are like, oh, you're a jack of all trades. You're not a specialist in anything. You don't know how to do blah, blah, blah. You just know a teeny bit of it. And I feel like, okay, like the home birth model is similar to the family medicine doctor, where like, you know so much of everything, but everyone kind of looks at you like, yeah, but it's kind of superficial. But like when you're interacting with the family is like, wow, you guys are deep. And it's like only the families that understand the value that you bring. And like, for example, like I was seeing this baby the other day or yesterday that wasn't quite at birth weight. And I am an OBGYN, yes, but I've made it a point to study postpartum neonatal development. Now, if you ever told a pediatrician that I'm the one that's checking this baby's jaundice and like doing its vitals and checking its birth weight, you know what I mean? And recommending supplementation at certain weight drops and stuff, they would be like, you don't know any of that. Like, you're an OBGYN. And the truth is, who gives a shit what my degree is? Whatever I learned, because I'm learning this too, and I learned it too, or else I wouldn't do it, because I don't want to be in jail. Like, I don't. Like, I think my family would be really upset if I was. So I'm not going to do it unless I know. And I know when I don't know enough, I refer, or call in my friends. And so, yeah, midwives and I love how you say out of hospital birth workers. We just have a lot more skill broadly. Yeah. But maybe not.
Well, and I think deeply too. I mean, there's so many pieces here. So much to unpick, right? But I would say one thing that I'm like, language and word medicine is really powerful to me. And this one thing I love to say is community-based birth, because we're not something. So out of hospital birth is still centering hospital.
Hey, you, podcast listener. I know that you've been enjoying this episode and you definitely don't want an interruption, so I'll be brief. Thank you so much for tuning in. Your support on our podcast means so much, and we'd love to know what you think. So we're inviting you to leave a review. Reviews help us grow, improve, and continue to create content that resonates with you. Whether it's shouting out your favorite episode, or giving us a suggestion for future topics, or just your overall experience listening to our show, your words make a difference. You can leave a review on whatever podcast platform you listen on. Scroll down to the reviews section, hit write a review, pour out your thoughts and feelings into the box, click submit, and know that you are single-handedly making a big difference for us. Thank you so much for being a part of our podcast family. Okay, let's get back to the conversation.
But yeah, I mean, I think the amazing thing is, or the thing that I think medicine got really wrong there's several medicine got wrong, but the march of its roots in 1940s, 1950s medicine, when the specialties started to really arrive, I think they got it wrong when they separated mothers and babies. Like, I think they got it so wrong.
Crazy
because who would be a better expert for that dyad? Yeah, totally wrong. Just like totally wrong.
Totally wrong.
I love that you're bringing it back.
You're so right.
I love that you're bringing it back.
Why? Like, I will say, and any OBGYN resident that's listening right now will know, they do not know what a neonatal's vitals are. They have no idea. They do not know what normal looks like when that baby comes out. Don't lie. You don't know if you're listening. You don't know how to transition a baby. You don't know what a low first APGAR means. It doesn't mean much. It doesn't. Sorry. I know everyone tries to freak out about that blue baby when it comes out. Doesn't mean much. They don't know normal weight gain. Maybe some that our mothers might know a teeny bit, but really probably not, honestly, because they're not even around to really see.
Which is such a sadness. It's such a sadness, because the mom and baby are a dyad, and to evaluate one's health without the other is actually dangerous.
Yeah.
You come to erroneous conclusions when you don't have the dyad. I like to teach midwifery students that it's like you have to, and that's how our eyes can't be separate from one of them. Like, we have to see them both at every visit, or we don't really know the whole picture. Yeah, I'm so glad you're bringing this back. I think that in itself is a revolution, Victoria. I cheer for you. It's awesome.
I'm so glad to have this talk. I totally agree. I've noticed that, like you said, once we separate it, it's like mom and a baby, and really, it's just like an extra uterine gestation when they're born, and like you kind of also have to consider that, like, they're so vulnerable even at birth that we can't, like, why do we just like care that they're out of the body. Like it's more than that.
And that's why that fourth trimester, right? Like right here is where they belong. We have to see them together. In fact, there was this great, I was an anthropology, sociology major, like in college before I did this whole thing. And there's these fantastic studies. I know, it's right. I love it. It's juicy stuff. There's these great studies about how when we became bipedal, you know, when the evolution of the species, babies had to be born sooner and sooner because of the way the pelvis changed shape. And so they actually are born smaller.
Oh, that's good.
Premature.
Okay.
They actually are born more neurologically immature compared to other mammals.
Yeah.
Like human babies are the most pupa-like of any mammal because they're biologically sooner than they used to be, right? Yeah. And so there really is this fourth trimester that exists from neurobiological development. They need to be right here. And yeah. I think you hit the nail on the head. Like this is all maternity care providers should have knowledge of newborn transitions and newborn growth and development.
Yes, I totally agree. I mean, great. We're on the same path. Yeah. We're in the same wavelength. Yes, absolutely. But it's so funny that you mentioned that. And the reason I was like gagging myself when I was listening to the like theory and evolution, this and that, because you know how many times they have in academic anthropology made really patriarchal mistakes about the female pelvis and about why the head goes down.
Oh yeah.
Right. And and it's just like, stop telling me what God did. Like I am observing it myself. And maybe I disagree, but because I'm not on a pedestal, like you're not going to give it credit. It's yeah. Yeah. You can see,
but the neurobiological immaturity is fascinating, right? I mean, it's fascinating that actually compared to other mammals, like chimpanzees can like hold on and latch themselves on the breast, and like baby gazelles can run away. Like there's like in terms of mammals, we are really immature, and so it's all the more reason to keep those mommies and babies together all the time. And there's some fantastic stories about how much better they do with resuscitation and how much better they do with their transition if they are touching mom. And of course, you know this in the home birth space, and it's pretty awesome. Well, I love that you got initiated into home birth. I love that Dr. Stu was one of your mentors. Tell me about some other mentors that you had in this space. What's that been like?
Honestly, I can name every midwife that I've worked with has taught me. Like that's how immature I was as a baby coming out in this space. Like, yeah, I had this degree, but every single beautiful woman that I worked with, it began, I guess, with Celeste Winfrey. Celeste Winfrey, one of the Black midwives. I think there's not many at all in California, and it's, really interesting. And she's in the San Bernardino community.
I know Celeste.
Yeah, my girl. She's my girl. So she began to take me to births with her because she needed an MD degree to get around some things. It was just like that. It was like, oh, I have a breech. Can you just like show up for this one? And oh, I need a vacuum. Can you show up for this one? Is that I don't want to transfer her. Or oh, I need a repair. Can you do this? Or something, little things like that. Like, oh, actually, this one needs a prescription that I can't write. Can you do that? Like, so she would just refer people to me, and that's how it began.
Yeah.
Oh, there's a space for me in
That's
this
awesome.
community work. And so I just kind of like let people pass along the service options by word of mouth because I didn't want to be too inundated. And then I got invited to other births, and, Lindsay Mealis has taught me so much. It's so funny. We realized we both were in the same goddess circles for a time. And we didn't know each other at that point, but we were like, wait a minute, this is super weird. And we both have our moon in the 13th house. So we're very birthy. Yeah. So then her, and then Stu, he always worked with beautiful midwives. He worked with, let me see, who was I working with? There was Tammy Stokes, where I got to work with her a lot. She's got a birth center out here. I got to work with Push Birth Center with Robin. She is awesome. She told me about how she put her kids through school by selling placenta pills early in the days when placentas were uncool, only for like those goopy LA girls. So I just got to learn some of the history of these women. And so I got to hear the history of the birth work. And yeah, it's just been beautiful. Kayleen, I worked with her. I've done about 2 or 3 twin births with her out here. She's awesome. She's about my age, and she's kind of like just badass energy. She does Crestline. Those are some that are just coming to mind right now. Of course, Barefoot Midwife, Lisa Marie. She's like a goddess in the space, right? So like
Yep.
so many. I mean, I'm missing a ton, like Jennifer Angel, and there's so many. There's just so many birds. I can't even go there. Nicole Morales and her team, so many. Hayes, unlicensed midwives, even, like, I'm supporting all of them. Like, it's just
That's
whatever.
amazing.
Yeah. And because I'm so fluent in physiology of adults too, I think that makes some women comfortable to have me in this space as well. Like, I get worried before everyone, kind of, and they kind of just go, no, it's okay. Or okay, if you think that, like, so we're good buffers for each other, bouncing ideas off
That's
each other.
beautiful.
We respect each other's assessments. It's no one's in charge. It's funny because sometimes I notice people want me to be like that in charge, but I'm just like asking, well, what do you see? And what do you think? And like, should I call the bus? The bus, what's the bus? Those types of things. I mean, I know I have a million other midwives that I'm totally missing right now. I'm so sorry, ladies.
Oh no, that's awesome. You
Yeah.
named a whole crew, and a shout out to all of them. Is it as different as we imagine it to be? Like going through a residency in the hospital compared to this apprenticeship and mentorship in the community-based space, is it as different as we imagine it to be?
Yeah, it's very different. It's super, super different. Super different, because I am in the hospital. We had labs to confirm suspicions, and there's been a tendency to not trust the physical exam in the hospital, whereas you have to trust the physical exam in the home birth space. You have to see what normal is with your eyes and your hands, your hearing, your sound, like how things smell. You have to use those senses, and you need to be very confident that you know what is off, and use those visual inspections and palpation for high blood pressure. Like, I told someone that in the hospital once, like, because my husband taught me like that he would just palpate blood pressure so that he could feel the differences in blood pressures with your hand. So I would learn that too. And I told someone that in the hospital. They're like, that's impossible. I'm like, well, what do you think a blood pressure cuff is doing? Like, it's feeling the pressure, like, and giving you the change in mercury change. You know what I mean? Like, it's giving you a rise or a fall in pressure and tightness that it needs to put air into this puffy sleeve, And so, yes, we rely way too much on numbers and tests and stuff in the hospital. And so that's why they keep doing them. That's why they keep doing blood draws and stuff. So it is very different in that regard. Also, because we're doing so many people at once every day, and it's a different person every time, there's not really a time to anchor your body in anyone's birth, because you have so much to do in the hospital that it isn't a smart idea to anchor. It's just not, because you're not going to get your work done, and then you're going to get fired. So it's not in your benefit to really stop and love someone and really hold them through the entire process. It's like, okay, I'll get back to you when they tell me that you need me. Bye. I got other things to do. And it's like the threat of your livelihood.
Wow.
Yeah. So women and men that have that need that to survive, then of course they're going to choose that over what could be out here. And I'm just lucky enough that I only get to do this for fun. Like, I'm doing it to pay off this grandiose student loan, like, and because I love it, not because I won't have a roof over my head. My husband's like, just quit. Let me just take care of you and be fine. But I love birth work, so I'm doing it.
Yeah. I love this. I love this about you. Well, so a few of you have done this, right? Like you and Stu and Nathan and Rebecca Cohen and David Hayes. And like, there's a few of you that have like left the mainstream industrial complex and are really happy in the community-based space. And there's a few midwives who are going the other way. Do you think that's a smart idea? Are you worried about that?
I have never heard that happening. I mean, it just seems, what do you mean they're going the other way?
Well, one really classic example, of course, is Aviva Romm.
Oh, that's right.
She was a midwife for 20 years and then went to Yale and is now an MD. And there's like, I know of one in Idaho and one in Louisiana.
Yeah, I think that there's this, and I know
Alabama, and there's about 5 I know of who are in med school right now. Yeah.
No, I get that question from midwives, like, should I go to medical school? Because once I get in, I'm going to change the system. And I'm like, no, you're not. I'm sorry, you're not. Like, I thought the same thing. That's why I did it. Like, I was that person that you're talking about. And you get there and you get beaten into a shape. and that's the shape that they want you to be in, or goodbye. Like, it's that way. Sorry, girl. Like, no one's going to be cracking that system open. It's going to do its own thing, and it's already burning itself to the ground. And you just got to watch it. Like, literally, it's burning itself to the ground. They're not hiring enough residents out of medical school, and that's bottlenecked by Congress, because Congress will only subsidize the pay of so many, and it's been the same since the 80s. When they thought there was going to be too many physicians per person, and now there's just not enough physicians per group population. And it's burning itself to the ground. There's way more suicides now. I think there was like 4 suicides in 7 months in one residency program in California. I won't say its name, but yeah, it's terrible. It's demoralizing. The system has made physicians work for a company instead of being independent and thinkers and critical thinkers that are free to practice the way that their heart drives them to. Now it's, you must do it according to this evidence-based flow chart with these limits that tell you what normal is, but you don't really get to see and learn normal on your own, which is a totally different understanding, because then you can see the body fluctuate through health and sickness at a level that's so fluid. But we're just looking at numbers, because does it fall in that range? Does it fall in that range? And so when women in, like, what I thought would be so funny is if you put an OBGYN, even an old OBGYN, like an 80-year-old, 90-year-old OBGYN, in a space with a midwife that knows natural birth, and ask them each that question and say, okay, OBGYN, you go first. What does natural birth look like? They're going to describe the Friedman-Meyer curve, right? They're going to describe how the S shape, like it's slow to go, slow to go, slow to go, active, fast to go, and then boom, it finishes really quick, right? They're going to talk about it like that. And that's just not how natural birth is. That's what a hospital birth looked like for a 20-year-old back in the 50s, right? But that's not natural birth.
With Pitocin.
Right, exactly. Probably also with Pitocin. You're right. I didn't even think about that. But it's a different energy.
They're augmented. Yeah.
Yes, exactly. But when you talk to a midwife, they're like, yeah, right. I wish my births went like that. No, it's like one night you labor and then it stops for the day. Another night you labor a little bit and then it stops. Another night you go labor, and you do this for a week. And then, maybe you'll get to complete the next day or in the morning, and then you're going to be pushing. And pushing isn't like right away all the time. Sometimes it is, but sometimes it's not. And it's okay, because it just depends. Like there's like so much more understanding for the way that the body walks itself there. Another mystery that was unfolded to me, and I'm sure this will be a mystery that's unfolded to some of your listeners, is that, well, then what the heck happens when a primate mom, first-time mom, goes into labor with like an OP presentation, occiput posterior presentation, cannot get to complete, gets to like 8, and then just peters out, like she's done. Like, what happens in nature? Does that baby die? Does that mom die? Does it? No, it doesn't. The cervix recoils, it becomes thick again, and that mom comes out of labor again, and that baby is fine and restores itself. And then maybe a week later, after the body feels like it has enough remineralization, enough power, enough rest, it will go into labor again, and probably so fast and so much more smoothly, because there was already an initial labor that occurred, that baby will make its rotations a lot easier. And probably get into, actually labor might not even start until that baby's in OA, or else it'll do it again. It'll just close the cervix up, the uterus will contract until the baby gets into the right position. And your body will go into labor several times until that baby comes out the right way. And that is like mind blowing. Like, no way. Like, if someone's at 4 centimeters, they're admittable because they're going to have a baby, right? No, that doesn't mean they're in labor. It just means they're like laboring a little. Like, we don't know yet, but we have to admit them.
I love this. Yeah, I feel really, I love this. I love this epiphany. I love what you're sharing.
Yes.
And I also feel like really, really blessed and really lucky. I oftentimes have said that I got the biggest head start in my midwifery career because I had very dysfunctional unassisted births. So I got to learn in my body what it feels like to be the sovereign birthing person without interference. I had a 5-week labor because it kept starting and stopping and starting and stopping because of that OP baby. And I had the faith to keep riding that wave. And she was eventually born persistent OP at 10 pounds. But it took 3 days of labor after those 5 weeks of labor, and it worked. And this is the piece where I think I get such a head start, this like deep well of faith and knowledge and trust in the process, to me, is both embodied and now also witnessed. And so it's this like, it's such a blessing. I think so many people have to learn it by repetition, and I got to learn it like repetition in my own body. So I'm grateful for that, even though it was like several
That's
nights of
awesome.
dark
Yeah,
nights of the
that's
soul. But yeah, but I got it in my body. I get it. You know, it was like 20. That was
yeah. And so even in that case,
that
the
was a
baby didn't
good
even have to get into the right position. Like
28
yeah.
years ago.
So in that case, the baby didn't have to get into the right position.
Slowly.
Yeah, it just eventually you're hit.
But there were at least 5 reasons.
Yeah.
Well, ligaments and
Yes.
you know, connective tissue, and like, you know, there's things that happen that we can't even measure, right? But like
Right.
were at least 5 reasons why I would have had a cesarean.
Right, exactly.
And that's that learning, right? Is this overuse of technology. I mean, I was 3 weeks late, and I was 10-pound baby and persistent OP and a 3-day labor, and like, you know, there's all these things, right? That you know, I would have definitely
I
been
love
cut if I had
it.
been anywhere else. And so this is that
Yes.
faith. And I know where I got my faith, but where did you get your faith, Victoria? Where did that bloom for you?
birth.
Yeah.
Do you mean faith in birth? I think I was gifted that, knowing from a very early age, probably 13, 14, 15, when I began goddess studies, about, you know, just understanding the role of the mother, and the birthing is a part of the culture and the talk, right? It's like always birthing out into the world what you want to manifest, what you want to work with, what you want to deal with, what lessons you need to learn. And so the word birth was really just always a part of my jargon from a young age. And so, and I always talked about it as birth just happens, because you don't like, there's no like labor stalling or failure to progress with your ideas. Like, so it was very much like birth always happens, like it just happens. And so when I started learning about these terms in the more medical way, it was really kind of confusing. And I was kind of in this cognitive dissonance of just like, what, like, that doesn't make any sense. Like, why are these women stalling? And then I get it now. Like, it's just because they're in the wrong place doing it, and they're expected to finish it the first time they start laboring. And I know any residents listening, they are probably like, bullshit, that cervix doesn't close. Like, once it's open, it only opens. And
I love this argument. It makes me laugh so hard. I'm like,
right?
You really have a question if the cervix can reverse dilate? What the hell do you think happens after the baby's born? Like, it's
Right.
like that. Of course it's an elastic muscle. Of course it can close. Like, that's craziness.
Yes. And it can close when the mom is tired, and, you know, all those things. So it's funny, because once I've transferred a person with like a dilation at like 7, she gets there and she's 4. They asked the doula because it says Dr. Flores, OBGYN. They're like, an OB didn't check this girl. Like, this girl's absolutely a 4. Like, there's no way an OBGYN would call this girl a 7. Like, and they're like, did you check her? And she's like, no, I have long nails. And she had these beautiful, like, long nails. And they're like, no. And they were so confused. They were like, well, this OBGYN must not know what she's talking about. Like, because that cervix is absolutely a 4. And I was just like, dudes, like, it closed. She was exhausted after 3 days. It closed. Like, I'm sorry that you've never seen that before. It's because you never allowed it to be seen before. Like, you're just like, oh, she's broken, let's C-section her. Like, it happens. And yeah, it's true. It's true, everybody.
Yeah. Reverse dilation it will happen anytime the pressure is no longer there. It is like the turtleneck, right? If there's no longer a head underneath it, it's closed. Like, it's elastic. That's what it does, you know? Yeah, that is awesome. I love it. They're like, and we've all been accused of that because of this very linear thinking.
Yes. Yeah. And I was saying that when I was being in training, like, all of the normal that I learned, you learn it from your residents mostly, and they teach. And one of the attendings was like, it's like the blind leading the blind. Like, it really is the blind leading the blind. Like, I remember one of my residents had taught me when I was like a first year, that how do you assess +2 station? And she was like, oh, it's when you can't push the head up anymore. Like, it's just, I was like, okay. So that's what I said when they asked me at rounds, like, what is +2? Oh, when the head is no longer blottable. And they were like laughing at me. And I just remember being like, well, I know that I read that it's the distance between this, the inner spinal diameter, or the spinous processes, whatever, ischial spines, and that distance. But my chief, or one of my senior residents, told me to say this, and they just thought it was hilarious. And I was just like, okay, I obviously can't make everyone happy. If I said this and I was right and she was wrong, I would have been punished, because women punish each other if they make another person look stupid. And then if I said the wrong thing, I was laughed at by the attendings. So it was just like, you have, it's terrible. It's terrible training in residency in that regard. And then I would ask, like, well, her cervix is a little bit less. And they'd be like, oh, there's no way. Like, there's no way. That means she's swelling. Do you remember that word? Oh, she's swelling. That means that she must not be able to tolerate labor. If her cervix feels thicker or smaller, it's because she's in pain and swelling, and we need to help her, because she's never going to dilate. She's going reverse because it's water. She's swelling. That was what they always said. Okay, we have to do a C-section. Yeah.
Oh, God.
Yeah. It wasn't just let her have some bone broth and sleep. And
to borrow from your goddess tradition, they're uninitiated, or they're partially initiated, then being required to initiate others. And that I think is the best way to describe what's happening in the medical world, is that in this to create big box healthcare, we have required the uninitiated to initiate others, which perpetuates this partial information being passed down on and on. And you were a victim of this. And unfortunately, I think almost all of OBGYNs are a victim of this. And then once they get out and in practice and shamed by colleagues, they then try to fit themselves into this narrow definition of who they are, what they're supposed to be, or what labor is, or how they're supposed to manage labor. And they don't get to experience the width and breadth and depth that is this amazing human rite of passage. And that's what I think is so profound about midwives, is that in the apprenticeship process, which by some miracle still exists, because it could have been stamped out, if we allow for this apprenticeship process to happen, then people enter the profession fully initiated. Mm-hmm. Mm-hmm. And then they can pass on a body of knowledge that is complete, and maybe even added to the next. That's what's so profound about midwifery. Mm-hmm. And I feel like midwifery and the midwifery model of care, and we could get even outside of midwifery, because it's really humanistic care. I mean, it's like it's so revolutionary, right? But that's what I'm really afraid of, is that this profession, this body of knowledge, is so under threat that we might lose it. And you are a part of the really important addition to this knowledge base. And I wonder, for those that are listening, either student midwives or residents, or folks who are planning to go to med school, or like anyone who's like in this world of having to dance between these two competing worlds, what advice do you have to them? What do you want them to do or be aware of now that you have access to this body of knowledge?
I think first and foremost is that you do not need to be able to read, speak good English, know proper grammar. You do not need to have a formal any education to help a woman have a baby. And I know that probably even upsets some licensed midwives. People can learn this and be 10 years old or 12 years old or 13 years old. And it's not hard, and it's not a lot of difficult information to digest. It's just an intuition of what is normal and what is not normal. And it doesn't always have to have numbers, and it doesn't have to have measurements. It's just a body having a baby, and it's so simple. And it sucks that we've, commodified birth to the point that people are teaching in schools how women birth babies. It's just like, they just do it. Like, they do it. We just have to create the place for them to do it safely and then help them when they do reach out. And it's not that hard. It's not. I think that's the biggest thing I would say to those academics out there that think that you have to be a brilliant genius and go through medical school, research, presentations and continuing medical education, CMUs, recertifications and board certifications in order to deliver a freaking kid. Like, is not necessary. Like, that is such an overkill and a waste of millions and millions of our students' money, dollars, and it holds a lot of people back in life. And I see women judged so much for their lack of ability to speak in the common vernacular, and that sucks. In the women of colored community, being held down just because the way that they express something is not the way that our culture accepts the language. It sucks. And correcting that, it's not necessary to correct women that say things different. It's not. At a heart level, they know it's happening. Sorry they didn't say it the way you would have said it. Women in a medical model definitely don't feel their own bodies. And I was in that space, and women in the out of the community environment are encouraged to feel their bodies in that space. And I think we just need to remind women in medicine to honor their own cycles instead of trying to become more of a male body. Yeah, it's easier. I'll tell you, having to be a bitch all the time and be like, and I'm saying that like jokingly, because like I'm sure that I was too, and having to like boss things around or like write orders and then kind of just set it and forget it. Like, it seems easy. And that's what men do. Like, that's what they do. They write a to-do list and they leave it on the desk of people to do the work a lot of times. And it's so easy that, it's tempting, but that's not what a woman's work is. It's not a woman's work. A woman's work is with other women. We are social, even if we don't have to talk with those women. Like, I am not really a super socially type of person, but when I'm with women and we're just quiet together, it feels really safe. And yeah, so just remembering our animal parts, remembering that we're animals too. That's just the way it is. And to remember that everything is living, not just us humans. And that's something that's also forgotten, is that, bringing in plant medicine, understanding that, and maybe this is too much for some of your listeners, but God is in it all, is in it all, in all. And if you acknowledge that spiritual energy in everything and say, I see you, I see what you're trying to do. You're trying to get this woman to stay alive. You're trying to get this baby to stay alive. I'm going to try and open a pathway for God to flow there. It makes it so much easier than just, cutting it down to numbers and managing numbers. It's just about managing energies and souls. And when you see it weakening, you try and find a way to build the fire to keep it going and encourage that energy to go forward. Yeah.
Victoria, what a pleasure to hear your advice, wisdom today. I hope we can stay connected and, dream up new things. I'm so excited for your future clients and colleagues.
Thank you so much. Thank you.